Hello dear students, in this video we will learn short stature, how to approach a child with short stature, how to differentiate between normal and pathological causes of short stature. Short stature is defined as a height that is 2 standard deviation or below the mean height for individuals of same gender and chronological age in a given population or third percentile. It is less than -2 standard deviation or third percentile. This is what the Nelson says. Short stature is defined as growing either below the expected genetic potential or growing below -2 standard deviation for age and gender in a given population. Now we will see the causes of short stature. Short stature is two types, proportionate or disproportionate. Proportionate is when the upper segment to lower segment ratio is normal. When it is abnormal, it is called disproportionate. What is upper segment, lower segment? The upper segment is from the vertex to pubic symphysis. Lower is up to heel. When it is proportionate, we have to see is it physiological or pathological. Physiological, there are two possibilities, familial or constitutional delay in growth and puberty. Now we will see what is familial short stature, constitutional delay in growth and puberty. In familial short stature, the entire family is short. In familial short stature, the family is as such short genetically. They are small at birth. Their length is small at birth, which is normal for the family. Their bone age is normal. They have normal age of onset of puberty. They also have short adult height like their parents. They are absolutely normal for their family. This is familial short stature. What is constitutional delay in growth and puberty? They have normal length at up to 6 months of age, then decreases for 2 to 3 years to become below the third centile. They have delayed bone age, delayed puberty, but ultimate adult height is according to the normal percentile. Here the clue is delay. They are delayed, follow the normal growth velocity, but ultimate adult height is according to the normal population. These are the causes of pathological short stature. Any chronic undernutrition like marasmus, nutritional dwarfism, any chronic systemic diseases like malabsorption syndromes, chronic hemolytic anemias, chronic renal failure, chronic chest diseases, chronic heart diseases leads to pathological short stature. The endocrine causes are hypothyroidism, hypopituitarism, Cushing's syndrome, precocious puberty, diabetes mellitus, diabetes insipidus. Psychosocial dwarfism also seen like due to disturbed maternal and infant relationship. The syndromes associated with short stature are Turner syndrome, Down syndrome, Prader-Willis syndrome, Seckel syndrome. 10 to 15% of the childs with intrauterine growth restriction will have short stature. Now we will see how to approach to a case of short stature. In the history, we have to first ask perinatal history for risk factors like any exposure, infections during the antenatal period, maternal drug intake. Birth weight and length should be noted to differentiate prenatal and postnatal causes. Problems like any hypoglycemia, microcephalus in the initial period should be noted. Any past history suggestive of chronic systemic diseases, endocrine disorders should be asked. In detail, dietary history should be taken to rule out the undernutrition or eating disorders. In the families, we should ask for parents' height, other short siblings, onset of puberty in parents and siblings, infant and mother relationship. On examination, we have to check parents' height to rule out the genetic causes, evidence of maternal neglect like dirty nails, bad infant and mother relationship. Assess pubertal development by Tanner's classification. Determine the type of short stature. Is it proportionate or disproportionate? Plot patient weight and height on appropriate growth charts. Clinical examination to rule out any endocrinal causes or skeletal dysplasias like muscle wasting, subcutaneous fat loss, signs of vitamin deficiencies. Complete systemic examination of cardiac, chest, abdomen, neurological examination to rule out other chronic disorders. Check for signs suggesting endocrine disorders. Check for signs suggesting dysmorphic features. Steps in the assessment are height measurement, then height velocity assessment, assessment of body proportions like upper segment ratio, lower segment ratio, arm span, sexual maturity rating, bone age estimation. Height velocity is the rate of increase in height over a period of time expressed as centimeters per year. If the height velocity is less than the expected for age, the child is likely to be suffering from pathological cause of short stature. Now we will see comparison with population norms. The height should be plotted on appropriate growth charts and expressed in centiles or standard deviation scores. Comparison with child's own genetic potential, for which we need mid-parental height, which gives an approximate estimate of child's genetically determined potential. This is how we will calculate mid-parental height for boys. We add 13.5 centimeters to father and mother's height, divided it by 2. For girls, we deduct 13.5 centimeters. For mid-parental height, we add plus or minus 10 centimeters to know the target range height at 18 years. This is the target height. This value is then plotted on the growth chart at 18 to 20 years of age. This gives an estimate of target height for the child and the percentile that he or she likely to follow at 18 years. And this is the at 18 years we give target height. Suppose his mid-parental height is 170. His target range is between 160 to 180, as we are deducting minus 10 and plus 10. So this is his target height at 18 years. It can't be single digit, right? So now we will learn how to measure the upper segment lower segment ratio and arm span. Bone age estimation is done by radiograph of left hand and wrist using Grealish-Pyle Atlas or Tanner-Whitehouse methods. We compare the radiograph of the child with the standard child. These are the things we have to see on head-to-toe examination. Investigations: assess the bone age of the child by left wrist X-ray after infancy. In newborn, we use knee X-ray. During infancy, we use shoulder. Search for systemic diseases by doing CBC, CRP, urine examination, stool analysis, ESR, RFT, chest X-ray, echocardiography, serum electrolytes, pH, calcium, phosphate and RBS. Hormonal assay as the second line investigations after ruling out the common causes, thyroid profile, growth hormone levels, serum urine osmolarity, CT skull for suspected pituitary tumor. These are the second line investigations. Chromosomal analysis, if any dysmorphic features are present, or treatment depends on the cause. Thyroxine for hypothyroidism, recombinant hormone replacement for hypopituitarism. Growth hormone can be supplemented in children with short stature of chronic renal failure, Turner's, thalassemia. Adequate balanced diet in case of undernutrition.